This video presents examination of the head, including inspection of the head, hair, scalp, skull, and face, examination of the eyes, including tests for visual acuity and visual fields, inspection of the eyes, and ophthalmoscopic examination, and examination of the ears, including inspection of the ears, otoscopic examination, and tests for hearing. In this video, the examiner will assess a healthy patient. Keep in mind that other patients may have the same normal findings or may exhibit normal variations or abnormal findings. During the eye inspection, observe the alignment and symmetry of the eyes. Also, examine the eyebrows and closely inspect the eyelids. Normally, the upper eyelid covers a portion of the iris but does not overlap the pupil. Inspect the area over the lacrimal gland and lacrimal sac for swelling. To inspect the conjunctiva and sclera, ask the patient to look up as you depress the lower lids with your thumbs. Normally, the palpebral conjunctiva is pink and uncongested. The bulbar conjunctiva is transparent with vessels running through it, and the underlying sclera is white. With oblique lighting, inspect each cornea and lens for opacities. To do this, shine a pen light from the side toward the eye. You should see no opacities. Even without side lighting, you may notice a corneal arcus in an older patient. This normal variation is a white ring around the periphery of the cornea. Carefully inspect each iris and pupil. Normally, iris markings are clearly defined and the pupils are round and equal in size.
Just look straight ahead and into the distance.
Continue assessing the pupils by checking their reaction to light. Observing one eye at a time, ask the patient to look into the distance. Then, from the side, shine a bright light into one eye and observe its pupillary response. The pupil should constrict briskly in direct reaction to the light. Now shine the light into the same eye again, but observe the pupillary reaction of the opposite pupil. It should constrict briskly in a consensual response. Repeat the process with the other eye. Watch for direct and consensual pupillary reactions again. If the pupillary light reaction is abnormal or questionable, test the near reaction. Hold your finger or a pencil about 10 centimeters from the patient's eyes and tell her what to do. Watch for pupillary dilation with distant gaze and pupillary constriction with near effort. Repeat this test if necessary, and then repeat it in the other eye. To assess the extraocular muscles, shine a light onto the patient's eyes from about 2 feet away. Ask her to look at the light. From just behind your light, observe its reflections. These should be visible slightly nasal to the center of the pupils. Now check the 6 cardinal directions of gaze. These directions correspond to the coordinated action of 6 muscles involved in eye movement, innervated by cranial nerves 3, 4, and 6. From 2 to 3 feet in front of the patient, ask the patient to follow your finger. Making a wide H in the air, lead the patient's gaze to the patient's far right, to the right and up, to the right and down, and without pausing in the middle, to the far left, to the left and up, and finally to the left and down. Eye movements should be symmetrical and conjugate. To detect nystagmus, pause during upward and lateral gaze. A few beats of nystagmus on extreme lateral gaze are normal. In a patient with lid lag, watch for a rim of sclera between the upper lid and iris as the eyes move up and down. To test for convergence, observe as the patient's eyes watch your finger move toward the bridge of the nose. Normally, the eyes converge and follow your finger to within 5 to 8 centimeters of the nose. When you're ready to examine the fundus, switch on the ophthalmoscope light and adjust it to the large round beam of white light. Also make sure the light is bright enough. Set the ophthalmoscope to 0 diopters. After darkening the room, ask the patient to look over your left shoulder at a specific spot on the
I want you to
wall.
look over my left shoulder.
Using your left eye and left hand, examine the patient's left eye. From 15 inches away and 15 degrees lateral to the patient's line of vision, shine the light beam on the pupil. Locate the red reflex, which should appear as an orange glow in the pupil. Note any opacities that interrupt the red reflex. While holding the red reflex in view, approach the patient's eye along a 15-degree line lateral to her line of vision until the ophthalmoscope is close to the eye. Try to find the optic disc by following the retinal vessels toward the place where they converge. Now bring the optic disc into sharp focus by adjusting the ophthalmoscope lens. Note the color of the optic disc, the clarity of its margin, and the size of the physiologic cup. Normally, the disc is yellowish-orange to creamy pink and round or oval with well-demarcated margins. It may be surrounded by white or pigmented rings or crescents. The optic cup-to-disc ratio is usually less than 1 to 2. Moving your head and instrument as a unit, inspect the retinal vessels and adjacent retina by following the vessels from the disc to the periphery in 4 directions. Note the relative size and color of the smaller, lighter arteries and the larger, darker veins. Look for changes such as nicking of the veins at arteriovenous crossings. There should be none. Examine the surrounding retina for hemorrhages or exudates, noting their size, shape, color, and distribution. Again, there should be none. Finally, examine the fovea and surrounding macula by directing your light beam laterally or asking the patient to look directly into the light. The tiny bright reflection at the center of the fovea may help orient you. To focus on more anterior structures, such as opacities in the vitreous or lens, change the diopter on the ophthalmoscope to more positive numbers, such as +10 or +12. Repeat the ophthalmoscopic examination on the patient's right eye using your right hand and right eye. Begin the eye examination by assessing the patient's visual acuity. To do this, have the patient stand 20 feet from a Snellen eye chart. If the patient wears contact lenses or general-purpose glasses, tell her to wear them. But ask the patient to remove reading glasses because they blur distance vision.
F, E,
Note the visual acuity
L,
printed at the side of the line of the eye chart.
E, Z, and D.
Now I'd like you to try to read the next line.
D, F,
Then repeat the test on the other eye. Remember to
D,
record visual
Z,
acuity
P,
using 2 numbers, such as 20/20, which is
L,
normal.
E, and F.
Now prepare to test the patient's visual fields. Directly face the patient from a comfortable distance and imagine a glass bowl encircling the patient's head. Ask the patient to look into your eyes. As you return her gaze, place your hands 2 feet apart lateral to the patient's ears. Then, at ear level, move your wiggling fingers along the imaginary bowl until the patient points to them. Repeat these movements in the upper and lower temporal quadrants. Normally, a patient sees both sets of fingers at the same time. If so, the visual fields are usually normal. Note that the eyebrows normally limit the visual fields in the upper temporal quadrants compared to the lower temporal quadrants and the directly lateral areas. Begin the ear examination by inspecting the auricle for position, size, and symmetry. Also, inspect the opening of the ear canal for discharge, swelling, or redness. If the patient has complained of ear pain or if you see signs of inflammation, check for tenderness by moving the auricle up and down and pressing firmly on the tragus. Pain on these maneuvers suggests inflammation of the ear canal. Also, press firmly on the mastoid bone behind the ear. Tenderness here suggests middle ear infection. Next, examine the ear canal and eardrum using an otoscope. To do this, select the largest speculum the patient's ear canal will accommodate. Position the patient's head so that you can see through the otoscope comfortably. Grasp the auricle firmly but gently, and in an adult, pull it up, back, and slightly out to straighten the ear canal. Then insert the speculum gently into the ear canal. Note any cerumen or earwax that may impair your view. Also observe for any discharge, foreign bodies, redness, swelling, or scaling. There should be none. Slide the speculum slightly down and forward and maneuver it until you can see as much of the eardrum as possible, including the pars flaccida if possible, and the margins of the pars tensa. Note the color and contour of the eardrum with its distinct cone of light. Normally, the drum is pearly gray. Also note the position of the handle of the malleus and inspect the short process of the malleus. The handle of the malleus, with the umbo at its tip, crosses the drum obliquely from the cone of light upward toward the short process. Be sure to examine the other ear in the same manner. For the next part of the ear exam, evaluate the patient's hearing. Occlude one of the patient's ears with your finger. Test the open ear by softly whispering numbers or words with two equally accented syllables from 1 or 2 feet away. Test one ear at a time. If hearing loss is present, gradually increase your voice volume until the patient can identify the spoken numbers or words. If hearing is diminished, do the Weber test, which checks for lateralization of bone conduction, and the Rinne test, which compares air and bone conduction. For each test, use a relatively high-pitched tuning fork, such as one of 512 Hertz. To do the Weber test, place a lightly vibrating tuning fork firmly on top of the patient's head. Ask where the patient hears the sound, normally in both ears or the midline. To do the Rinne test, place a lightly vibrating tuning fork on the mastoid bone behind the ear. When the patient indicates that the sound is no longer heard, quickly place the vibrating fork close to the ear canal. Normally, the patient can hear vibration longer through air than through bone.
Can you hear this?
Repeat the test on the other ear.
Tell me when it stops.
Begin your examination with inspection of the head. Observe the size, shape, and position of the head, as well as its proportion to the neck and the rest of the body. Inspect the hair, noting its quantity, texture, distribution, and pattern of loss, if any. Part the hair in several areas to inspect the scalp.
Have you noticed any problems?
Observe for scaling, lumps, lesions, scars, and nits, or lice eggs, which are tiny white ovoid granules that adhere to hairs. Palpate the scalp and skull for masses and tenderness. When examining the patient's face, observe it at rest and during conversation. Also, assess the color and condition of the skin on the face. Look for skin lesions, scars, masses, edema, and unusual pigmentation or facial hair. In summary, examination of the head, eyes, and ears includes inspection of the head, hair, scalp, skull, and face. Tests for visual acuity and visual fields. Inspection of the eyes. Ophthalmoscopic examination. Inspection of the ears. Otoscopic examination. And tests for hearing.